We are excited to present this valuable webinar on behavioral health and substance use disorder. This presentation has been approved by the AAPC for 1 CEU. Please note you must attend at least 75% of the presentation in order to be awarded your certificate. After attendance has been verified, certificates will be emailed to you and with your email address provided within the registration link. This presentation is intended for both physician and office staff. The information contained in the presentation and responses to the questions are not intended to serve as official coding or legal advice. All coding should be considered case-by-case basis and should be supported by medical necessity and the appropriate documentation reflected within the medical record. This presentation recording will be available on our Blue Cross Blue Shield provider risk adjustment webpage. Throughout the webinar, the chat box will remain open for you to submit your questions. We will answer all questions pertaining to the webinar's topic in an email when we send out your CEU certificate. We will have a few coding scenarios throughout the webinar, so please have your coding book or encoder ready. Before we begin, I want to take a moment to introduce our risk management team and some of our presenters for today. Our team is comprised of nurses and coders that have worked in an array of settings with many years of experience. I want to outline some goals we have for today's webinar. Our goal is not to make you experts with behavioral health and substance use disorder coding, but rather introduce some key code sets and guidelines for it. We are hopeful after this webinar, participants will gain understanding of these conditions and how to code to the highest level of specificity. We have a lot to cover today, so let's get started. We will begin with substance use, abuse, dependence, and remission. It is important to understand the different levels of substance use for accurate diagnosis and effective treatment planning. First, substance use refers to the consumption of substances such as alcohol or drugs or other chemicals. This use can be occasional or social and typically does not result in significant negative consequences. Characteristics of substance use include casual or recreational use without major impact on daily responsibilities or relationships, and controlled moderate consumptions. Next, abuse describes a pattern of harmful use of substances that leads to significant impairment or distress. Key characteristics include recurrent use, resulting in failure to fulfill major role obligations at work, school, or home, using substances in physically hazardous situations, encountering legal problems related to substance use, and continuing use despite persistent social or interpersonal problems. Finally, a dependence is a more severe form of substance use disorder. It is marked by physical and psychological dependence on a substance. Characteristics include tolerance, where more of the substance is needed to achieve the same effect or there is a diminished effect with the same amount. Withdrawal symptoms when not using the substance or using it to avoid these symptoms, using larger amounts or for a longer duration than intended, persistent desire or unsuccessful efforts to cut down or control use, significant time spent obtaining, using, or recovering from the substance, giving up or reducing important social, occupational, or recreational activities, and continued use despite knowing it causes physical or psychological problems. Substance abuse includes various categories, each with unique risk and characteristics. Alcohol dependence involves a strong craving and difficulty controlling intake, leading to serious health issues like liver disease. Opioids, including prescription painkillers and heroin, have a high potential for misuse and overdose. contributing to the opioid crisis. Tobacco use, primarily through cigarettes, is a leading cause of preventable death due to risks like lung cancer and heart disease. Cannabis, used both recreationally and medicinally, can lead to dependence and cognitive issues. Sedatives and hypnotics, such as benzodiazepines, are highly addictive and can cause severe withdrawal symptoms. Cocaine, an illegal stimulant, poses serious health risks, including heart attacks and mental health problems. Caffeine, commonly found in beverages like coffee and energy drinks, can cause dependence and anxiety when consumed excessively. Hallucinogens, such as LSD, alter perception and mood, potentially leading to psychological distress and accidents. Lastly, volatile solvents, often inhaled from household products, can cause significant damage to the brain, liver, and kidneys, sometimes resulting in sudden death. Let's take a deeper dive into alcohol use disorders. These are medical conditions that are diagnosed when a person's drinking of alcohol causes major concerns or harm and a decrease in the ability to function. Alcohol use disorder can be classified as mild, moderate, or severe. Risk factors for developing alcohol use disorder are family history, depression, and other mental health problems, as well as a history of trauma. The reason these last two risk factors are important is in the possible development of alcohol use disorder is that people sometimes use alcohol to self-medicate their depression or trauma. Alcohol can seem like it is working to make people feel better, but it does not continue to work in the treatment of these other disorders. The symptoms of alcohol abuse are things like not being able to stop drinking once it started, feeling irritable or upset when unable to drink alcohol, frequent hangovers, problems at work or school, problems with relationships, and problems with law enforcement. In addition to these kinds of issues, alcohol over time can cause medical issues. These medical issues include liver, stomach, and pancreatic diseases, heart arrhythmias, diabetes complications, and an increased risk of developing cancer, to name a few. There are several different treatment approaches for alcohol use disorder. One size does not fit all, and a treatment approach that may work for one person may not work for another. Treatment can be outpatient or inpatient and be provided by specialty programs, therapists, and healthcare providers. The three basic categories of treatments are medications, behavioral treatments, and mutual support groups. There are several medications to help people stop or reduce their drinking and prevent a return to drinking. All of these medications are non addictive and they may be used alone or combined with behavioral treatments or mutual support groups. Behavioral treatments, also known as alcohol counseling or talk therapy, are provided by licensed therapists and are aimed at changing drinking behavior. Mutual support groups such as Alcoholics Anonymous or AA provide peer support for stopping or reducing drinking. Please note, people with severe alcohol use disorder may need medical help to avoid alcohol withdrawal if they decide to stop drinking. Alcohol withdrawal is a potential life-threatening process that can occur when someone who has been drinking heavily for a long period of time suddenly stops drinking. Doctors can prescribe medications to address these symptoms and make the process safer and less distressing. Now that we have explored some terms and the substances that are used, let's look at the definition of remission. Remission is important in coding because it has specific criteria that must be documented by the provider. Full remission occurs when 2 months have elapsed, either without the patient experiencing significant symptoms or without the patient meeting DSM-5 criteria for the disorder. Partial remission entails either no experience of significant symptoms or the patient's symptoms to meet the DSM-5 criteria for the disorder within a 2-month period of time. However, clinical determinations of partial and full remission should again be left up to your provider. Remember, remission determination requires the provider's clinical judgment and documentation of the words in remission. When coding diagnoses related to substance use, remember to look for and encourage your providers to document specifically: is there abuse or dependence present? Is it current, recurrent? If in remission, is it partial or full? What is the severity of the condition, mild, moderate, or severe? Are there current symptoms such as intoxication, withdrawal, or psychosis? How many substances are involved? Make sure each substance is addressed independently and documented as described above. Keep in mind that when the provider documentation refers to use, abuse, and dependence of the same substance, alcohol, opioid, cannabis, etc., only one code should be assigned to identify the pattern of use based on the following hierarchy. If both use and abuse are documented, assign only the code for abuse. If both abuse and dependence are documented, assign only the code for dependence. If use, abuse, and dependence are all documented, assign only the code for dependence. If both use and dependence are documented, assign only the code for dependence. Let's review a few scenarios regarding use, abuse, and dependence. The patient presents with alcohol use code F10.90. This code is used for general alcohol use that is unspecified and uncomplicated. It applies when a patient consumes alcohol but doesn't meet the criteria for abuse or dependence. The second scenario, the patient presents with alcohol use and abuse. You would code F10.10. This one is for alcohol abuse without dependence. It's for when a patient shows harmful drinking patterns, cause significant impairment or distress, but hasn't developed dependence. Our third scenario, the patient presents with alcohol abuse and dependence, code F10.20. This code indicated alcohol dependence uncomplicated. It's used when a patient has developed a dependence on alcohol, which can include tolerance, withdrawal symptoms, or a strong desire to drink. The fourth one, a patient presents with alcohol use, abuse, and dependence code F10.20. This code is again for alcohol dependence, uncomplicated, which applies when the patient meets the criteria for use, abuse, and dependence without complications. And in the last scenario, a patient presents with alcohol abuse and dependence in remission, code F10.21. This code is for when a patient who was previously diagnosed with alcohol abuse or dependence has stopped drinking recently or for a long period. It means they are in remission. Now let's talk about medical conditions due to substance use. These medical conditions due to substance use, abuse, and dependence are not classified as substance-induced disorders. They are coded separately. Assign the diagnosis code for the medical condition as directed by the alphabetical index along with the appropriate psychoactive substance use, abuse, or dependence code. For example, for alcoholic pancreatitis due to alcohol dependence, assign the appropriate code from subcategory K85.2, alcohol-induced acute pancreatitis, and the appropriate code from subcategory F10.2, such as code F10.20, alcohol dependence uncomplicated. It would not be appropriate to assign the code F10.288, alcohol dependence with other alcohol-induced disorder. Now let's talk about mental disorders due to substance use. These are coded differently. Substance medication induced mental disorders refer to depressive, anxiety, psychotic, or manic symptoms that occur as a physiological consequence of the use of substances of abuse or medications. It may occur during active use, intoxication, or withdrawal. These mental disorders that are caused by the substance are coded within the substance categories. For example, a patient presents with cannabis dependence with cannabis-induced anxiety disorder. There is one code for this, F12.280. Let's review some documentation and coding tips for substance use. It's important to specify the substance and the severity of the disorder. This helps ensure accurate coding and reflects the full complexity of the patient's condition. For example, opioid dependence is coded differently from opioid abuse, and each has its own ICD-10 code. For patients in remission, make sure to clearly document whether they're in early or sustained remission. This information has a direct impact on risk adjustment, so using the correct ICD-10 codes like F11.21 for opioid dependence and remission is necessary. Don't forget to document any complications or coexisting mental health conditions. If a patient has alcoholic liver disease or an anxiety disorder related to substance use, those should also be captured with additional codes, which impacts the overall risk score. Now let's try a coding scenario. In the assessment, the patient is alcohol dependent in remission for 8 years. In the plan, the patient is encouraged to continue abstinence and continue AA attendance. What code would you assign? You can put your answer in the chat. We would assign code F10.21, alcohol dependence in remission. Full remission occurs when 2 months have elapsed either without the patient experiencing significant symptoms or without the patient meeting the DSM-5 criteria for the disorder. Remember, in remission requires the provider's clinical judgment and documentation. We can't assume that they are in remission. It must be documented. Now let's discuss mood disorders. As you can see, these are the F30, 31, 32, 33, 34, and 39 codes. We'll be touching on each one of these. Let's start with F32, depression. Depressive disorders are characterized by sadness, severe or persistent enough to interfere with function, and often there is also decreased interest or pleasure in activities. In order to screen for depression, a doctor may ask people to fill out a standardized questionnaire to help identify depression and determine how severe it is. But the questionnaires cannot be used alone to diagnose depression. Let's take a look at some of these tools. The PHQ-2 is a brief self-administered questionnaire that assesses depression symptoms. This shorter test is derived from the original and longer PHQ-9 assessment. The purpose of the PHQ-2 is to screen for depression in a first-step approach. Patients who screen positive should be further evaluated with the PHQ-9 test. The PHQ-9 assessment addresses multiple mental health concerns, including depression, panic disorder, anxiety, sleep disorders, and others. The Hamilton Depression Rating Scale, also known as the HAM-D, is the most widely used clinician-administered depression assessment scale. The original version contains 17 items pertaining to symptoms of depression experienced over the past week. The Beck Depression Inventory, BDI, is a 21-item self-report rating inventory that measures characteristic attitudes and symptoms of depression. The BDI has been developed in different forms, including several computerized forms as well as the hard copy forms. The BDI takes approximately 10 minutes to complete, although clients require a 5th to 6th grade reading level to adequately understand the questions. Doctors also use specific lists of symptoms or criteria to diagnose the different types of depressive disorders. To help distinguish depression from ordinary changes in mood, doctors determine whether the symptoms are causing significant distress or are impairing the person's ability to function. A previous history of depression or a family history of depression helps support this diagnosis. Once depression has been diagnosed, it must be treated. Treatment depends on the severity and type of depression. For mild depression, support, including frequent doctor visits and education and psychotherapy, can help. For moderate to severe depression, drugs, psychotherapy, or both, and sometimes electroconvulsive therapy known as ECT, are used. Seasonal affective disorder or seasonal depression occurs at the change of seasons when daylight hours decrease. Phototherapy, which uses special lamps that mimic daylight, can be very helpful. Prolonged grief disorder, psychotherapy is tailored to this disorder and is recommended. MDD or major depressive disorder is a severe form of depression where, in addition to a depressed mood and loss of interest in doing any activity, the patient also experiences changes in weight or appetite, too much or too little sleep, slowed motor function, loss of energy, indecisiveness, and feelings of worthlessness that may be accompanied by suicidal thoughts. When coding MDD, it's critical to capture the episode meaning, whether it's single or recurring, and then capture the severity as well as if there is any kind of remission documented. Specificity is key in forming an accurate picture of what is happening with the patient. The unspecified codes on the right side of the slide, F32.9 and F32.A, should rarely be used and only when nothing else, such as the severity or episode, is known about the disorder. Let's drill down a bit further with the severity of the condition. So once we've decided whether or not the documentation supports F32 or F33, then we need to decide the severity. Categories F32 and F33 are further subdivided with third characters and sometimes fourth characters to provide information about the current severity of the disorders. So on the slide, let's take F32.0, and that is major depressive disorder, single episode, mild. Apply that nomenclature to the rest of the severity categories. 1 is moderate, 2 is severe without psychotic features, 3 severe with psychotic features, 4 partial remission, 5 full remission, 8 other depressive episodes, and 9 unspecified. And here's an important note. Third characters 0 through 5 are assigned only when the provider documentation of severity is included in the medical record. Remember, accurate and specific documentation not only helps with coding, but also contributes to better patient management and care continuity. So let's make it a practice to capture the severity level comprehensively. Now let's move to bipolar disorder, also known as manic depression and the F31 category. People who have this serious illness go through unusual mood changes. They go from very happy, up and active, to very sad and hopeless, down and inactive, and then back again. They often have normal moods in between. The up feeling is called mania, and the down feeling is depression. Treatment consists of different classes of medications used alone or in combination, such as a mood stabilizer, antipsychotics, antidepressants, and anti anxiety drugs. There are two types of bipolar 1 and bipolar 2. What is the main difference between these two? The main difference between bipolar 1 and bipolar 2 disorders lies in the severity of the manic episodes caused by each type. A person with bipolar 1 will experience a full manic episode, while a person with bipolar 2 will experience only a hypomanic episode, a period that's less severe than a full manic episode. As with all mood disorder codes, it is important for your providers to document the correct category, bipolar 1 or 2, with or without psychotic features, with the severity or remission status. If none of that information is documented and you only have the diagnosis of bipolar, use F31.9 bipolar disorder unspecified. Let's now take a look at the F30 codes. These include manic episodes or mania. There is a reminder in the slide of the F codes we've discussed already. The F30 codes require fourth and fifth or fifth digits to identify the severity of the current episode and whether or not psychotic symptoms are involved. A manic episode may be elevated, expansive, or irritable in nature. Manic episode mood changes typically last for at least a week, or if less than a week, are severe enough to require hospitalization. F30 codes are used to identify a single episode of mania. Select appropriate fourth and fifth digits to identify the severity of the current episode to indicate whether psychotic symptoms are involved. So, for instance, documentation of someone with a mild manic episode without psychotic symptoms would be coded as F30.11. The fourth digit indicates without psychotic symptoms, and the fifth digit indicates mild severity. In the second row, F31, these codes are all of the bipolar codes. And as we just discussed, these codes describe the serious mental illness with severe mood swings, both manic and depressive. The F34 codes describe persistent mood disorders. This category is used to classify conditions whose primary feature is a disturbance in mood, but whose symptoms do not meet the severity of those categorized to major depressive, manic, or bipolar disorders. And the F39 codes are unspecified mood affective disorders. Here are some tips for documenting and coding mood disorders. Be specific about the type of disorder, whether it's depression or bipolar disorder. Each needs its own ICD-10 code. For example, major depressive disorder is coded differently from bipolar disorder, so capturing the right condition is necessary. It's also helpful to include the severity of the disorder and whether the patient is experiencing an acute or chronic episode. For instance, a severe recurrent major depressive disorder, F33.2, is coded differently from the mild single episode, F32.0. If the patient has psychotic features or if the mood disorder is in partial or full remission, these should be documented as well, as they influence the final coding. This level of detail ensures a complete picture of the patient's mental health and appropriate coding. Okay, let's take a look at a coding scenario for mood disorders. Mr. Bell was diagnosed with bipolar disorder and major depressive disorder, recurrent mild. What code is assigned when both conditions are documented? Please note the coding tips for this scenario. Category F31, bipolar disease, has an excludes one note for major depressive disorder, recurrent, F33. And category F33, major depressive disorder, recurrent, has an excludes one note for bipolar disorder, F31. Go ahead and put your answers in the chat. You would assign F31.9, bipolar disorder unspecified. It's important to remember that bipolar disorder includes episodes for both depression and mania. In this case, there were no additional documentation provided regarding the type, severity, or psychosis status of the bipolar disorder. Since this specific information wasn't available, we used the unspecified code F31.9 for bipolar disorder. Now I will hand it over to my colleague Christy to discuss dementia.
Good afternoon. Now we will take a look at dementia. What is dementia? Chances are you have known someone that has been impacted by some form of dementia. Some of us have experienced firsthand the caregiving responsibilities associated with this group of conditions. Let's start by clarifying that dementia is not a specific disease. Dementia is a group of conditions or symptoms that are characterized by impairment of at least two brain functions, such as memory loss and judgment. Symptoms include forgetfulness, limited social skills, and thinking abilities so impaired that it interferes with daily functioning. Dementia is a syndrome in which there is deterioration in cognitive function beyond what might be expected from the usual consequences of biological aging. There is significant impact and loss of memory and cognitive ability that is severe enough to interfere with daily life and one's ability to independently function. A common progressive manifestation associated with this disease is behavior changes. Some of these may include aggressive behavior, becoming less active, impulsive or disinhibited behavior, and emotional outbursts. Dementia typically progresses slowly in three stages: early, middle, and late, sometimes referred to as mild, moderate, and severe in a medical context. Dementia will usually go through each of these stages. However, depending on the person and the area of the brain involved, it can vary. In the early stages of dementia, a person may not experience any symptoms but have a lab test to reveal a problem. He or she may still drive, work, and be part of social activities. You may notice slight changes in behavior, but your loved one will still be independent. Symptoms may include problems with making plans and remembering recent events or repeating themselves a lot. The middle stages of dementia are typically the longest and can last for many years. During these stages, the individual will have more problems with making plans and remembering recent events. They may experience more difficulty with traveling and handling money. Worsening symptoms may also include the inability to remember their phone number or their grandchildren's names. They may become confused about the time of day or the day of week. During this stage, the individual will need assistance with some basic day to day functions, such as picking out clothes to wear. In the late stages of dementia, an individual will begin to forget more things, such as the name of their spouse. They will require more assistance with routine tasks, such as toileting and eating. They may also experience changes to their personality or emotions. In the final stage of dementia, an individual can no longer speak their thoughts, cannot walk, and will spend most of their time in bed. The most common form of dementia among older people is Alzheimer's disease. With this disease, brain neurons stop functioning, lose connections with other neurons, and die. Alzheimer's disease onset is generally over the age of 65 and is the leading cause of up to 70% of dementia cases. According to the CDC, minorities and women are more likely to develop Alzheimer's disease. Symptoms may include increased need for assistance with activities of daily living, including dressing, eating, and bathing. Individuals may have trouble remembering recent events, the names of people they know, and eventually may not recognize family members. Ultimately, total care will be necessary for these patients. Currently, there is not a cure for Alzheimer's disease. Symptoms can be managed with a variety of approaches, which we will discuss later in the presentation. One cause that is specific to Alzheimer's is the buildup of the beta amyloid protein. Abnormal levels of this naturally occurring protein clump together to form amyloid plaques. These collect between the neurons and disrupt cell function, resulting in the symptoms related to Alzheimer's disease. As neurons are injured and die throughout the brain, connections between networks of neurons may break down, and many brain regions begin to shrink. By the final stages of Alzheimer's, this process, called brain atrophy, is widespread, causing significant loss of brain volume. Other contributors to Alzheimer's disease symptoms include neurofibrillary tangles and chronic inflammation. The G30 category is used to code Alzheimer's dementia. As always, it is important to code to the highest specificity known. Conditions such as behavioral disturbances, anxiety, and psychosis should also be captured and coded using codes from the F05 and F02 code sets. Another neurodegenerative disorder is Lewy body dementia. In this form of dementia, abnormal deposits of a protein called alpha synuclein affect chemicals in the brain, whose changes in turn can lead to problems with thinking, movement, behavior, and mood. Symptom development and change varies greatly from person to person. The disease lasts an average of 5 to 8 years from the time of diagnosis to death. To code Lewy body dementia, you will use ICD code G31.83. You will also use code F06.7 to describe any mild cognitive disorder or impairment caused by the underlying Lewy body diagnosis. These conditions will reflect an impairment in memory, or thinking that is beyond what is considered normal for age related symptoms. Vascular dementia describes problems with reasoning, planning, judgment, memory, and other thought processes caused by brain damage from impaired blood flow to the brain. This can develop after a stroke blocks an artery in your brain. It can also develop from other conditions that damage blood vessels and reduce circulation. A few examples of these include smoking, diabetes, and chronic alcohol use. Vascular dementia symptoms vary depending on the part of your brain where blood flow is impaired. Symptoms often overlap with those of other types of dementia, especially Alzheimer's. Symptoms include slowed speed of thinking, delusions, and short term memory loss. When coding vascular dementia, you will choose from the F01 code set. Providers should be encouraged to include the severity of the condition in their documentation. You will also have the provider identify and document the underlying physiological condition that has caused the interruption of blood flow, such as stroke or chronic alcohol use. Next, we have frontotemporal disorders, sometimes called frontotemporal dementia. These are the result of damage to neurons in the frontal and temporal lobes of the brain. A variety of symptoms can result depending on the location of the neuron damage. Frontal lobe symptoms include behavioral symptoms such as impaired judgment, difficulty controlling emotions, depression, and falling. When the temporal lobe is affected, symptoms may present as difficulty understanding spoken words, difficulty with identification of objects, and difficulty learning and retaining new information. You will use a code from the G31 code set to communicate diagnoses from this dementia category. You will also include additional codes from the F02 code set to reflect any behavior disturbances, anxiety, or psychosis. Diagnosing dementia has three parts. Part one is a cognitive test. This will include questions to the patient to evaluate for short term memory loss. During this assessment, eye movement, speech, and sensation are also measured. Other assessments include a depression screen and mood assessment. Since different areas of the brain can be affected, it is important to include a variety of assessments to note changes within each of the different areas that the brain services. Another piece to obtaining a dementia diagnosis includes a variety of brain scans. A CT scan can be used to identify areas in the brain which may show shrinkage, a sign of neuron damage or death, signs of a stroke, new or old, a brain tumor, and other abnormalities. An MRI will provide detailed images of the body, including tissues, organs, bones, and nerves. An MRI can also show if the patient has high levels of beta amyloid protein, the protein that makes up the plaques found in Alzheimer's patients. Finally, a PET scan can be used to diagnose dementia by measuring the concentration of glucose in the brain to reveal how the brain is utilizing energy, or it can be used to measure the buildup of abnormal amyloid protein in the brain. Lastly, there are a few additional tests available to assist with diagnosing dementia. Genetic testing can be used to look for genetic variations that affect someone's risk of developing dementia. Cerebrospinal fluid testing can be performed to measure the levels of some proteins or other substances that may indicate the presence of dementia, and also blood tests to measure levels of the beta amyloid protein. These additional tests should not be used independently to diagnose dementia, but be used to supplement other testing as directed by the provider. Now that we have discussed the different types of dementia and how to diagnose them, let's talk about the various treatments available and a few tips for caregivers. Most people want to maintain their independence for as long as possible. Many also want to stay home or with family instead of a facility. A few things to consider having in the home include handrails for stairs and showers, grab bars for bathtubs, securing large pieces of furniture, and removing tripping hazards such as throw rugs. Another important piece to remember is a centralized location, perhaps the fridge, for emergency contact numbers. Code set Z55 through Z65 include codes related to social determinants of health. These challenges should be considered and documented during visits when working with this population. Interventions placed prior to an incident are ideal, and tracking these risks can help. Inability to obtain utilities and adequate food are important to know as well as inadequate housing, environmental temperature. Social determinants of health code assignment can be based on documentation from non provider clinicians. For example, coding professionals may utilize documentation of social information from social workers, community health workers, case managers, or nurses if their documentation is included in the official medical record. Detailed interviewing of these patients and their caregivers is important when trying to keep them safe at home. Routines are stored in long term memory. However, dementia also usually affects short term memory initially. Routines may remain accessible into the middle stage of the disease. Keep bath times and getting dressed at the same time, whether morning or evening. This will reinforce a sense of order and purpose. There's a variety of medications available to treat dementia. The stage and severity of the patient's dementia should be considered when choosing a medication. Some medications, such as Aduhelm, reduce the buildup of the amyloid beta protein found in Alzheimer's patients to slow the progression of the disease, while others, such as Namenda, block certain substances in the brain that are linked to symptoms of Alzheimer's disease, therefore reducing the symptoms presented. Symptoms can be managed across all types of dementia using a variety of medications. Medications may be prescribed to manage sleep disturbances, anxiety or agitation, and hallucinations. Be sure to include the symptoms experienced with your dementia diagnosis coding as appropriate. Let's talk about some coding tips and documentation for dementia. Make sure to specify the type of dementia, whether it's Alzheimer's, vascular dementia, or Lewy body dementia. This specificity ensures accurate coding. Behavioral disturbances like agitation or psychosis need to be clearly documented. For example, vascular dementia with behavioral disturbances uses a different code than without behavioral disturbances. Additionally, don't forget to include the severity or stage of the dementia, whether it's early or late onset. This helps in coding for the appropriate level of care the patient requires. Lastly, if the dementia affects the patient's ability to perform daily tasks, it's helpful to document that impact as well for accurate coding. Here's a coding scenario. A patient with known severe dementia due to late onset of Alzheimer's disease is admitted from a senior living facility due to increased agitation and combativeness over the past 3 days. What is the appropriate code assignment for severe dementia in a patient with agitation and combativeness? Please place your answer in the chat. You would assign codes G30.1, Alzheimer's disease with late onset, and F02.C11, dementia and other diseases classified elsewhere, severe with agitation. Now let's turn our attention to personality disorders. Personality disorders are a group of mental health conditions characterized by persistent and enduring patterns of behavior, cognition, and inner experience. These patterns significantly deviate from what is expected with an individual's culture. Key characteristics of personality disorders include their pervasive and inflexible nature, meaning these patterns are consistent across many different situations and are difficult to change. They typically begin in adolescence or early adulthood and remain stable over time. Personality disorders are mental health conditions that significantly affect the way a person thinks, feels, and behaves. They can make it challenging for someone to maintain relationships, hold down a job, or even manage day to day activities. Personality disorders are generally grouped into three clusters based on their characteristics. First, we have cluster A, which includes disorders that are often seen as odd or eccentric. Exa- Examples are paranoid personality disorder, schizoid personality disorder, and schizotypal personality disorder. People with these disorders might be seen as distant or distrustful. Next is cluster B, which includes dramatic, emotional, or erratic disorders. Examples are antisocial personality disorder, borderline personality disorder, histrionic personality disorder, and narcissistic personality disorder. People with these disorders tend to have intense emotional reactions, difficulty maintaining relationships, and may act impulsively or seek excessive attention. Lastly is cluster C, which includes anxious or fearful disorders. Examples are avoidant personality disorder, dependent personality disorder, and obsessive compulsive personality disorder. Individuals with these disorders may struggle with chronic fear or anxiety, avoiding social situations, or displaying perfectionistic tendencies. Treating personality disorders typically involves a combination of psychotherapy and, in some cases, medications. Psychotherapy is the primary treatment and includes several approaches. Cognitive behavioral therapy helps patients identify and change negative thought patterns and behaviors. Dialectical behavior therapy is particularly effective for borderline personality disorder. DBT focuses on emotions regulation, mindfulness, and improving interpersonal skills. Psychodynamic therapy is an approach that explores past experiences and emotions to understand and influence current behavior. Medications can be used to treat coexisting symptoms or conditions. Antidepressants are useful for managing depression or anxiety. Mood stabilizers help with mood swings and impulsivity, and antipsychotics are prescribed for severe symptoms like paranoia or psychosis. In addition to professional treatments, there are several tips for managing personality disorders. Consistent therapy, regular sessions with a qualified therapist are crucial for long term management. Systems, building and maintaining strong relationships with supportive family and friends can provide emotional support and stability. Self care, engaging in activities that promote physical and mental well being, such as regular exercise and hobbies, can be very beneficial. Mindfulness and relaxation techniques. Practicing mindfulness, meditation, or yoga can help manage stress and improve emotional regulation. And education. Learning about the disorder helps individuals understand their symptoms and triggers, which can enhance self awareness and coping strategies. By combining these treatments and self management tips, individuals with personality disorders can improve their quality of life and achieve better mental health. Now we have another coding scenario. A patient with long-standing diagnosis of avoidant personality disorder is presenting with increasing social withdrawal and refusal to attend work or social gatherings for the past month due to fear of criticism and rejection. What is the appropriate code assignment for avoidant personality disorder? You would assign code F60.6, avoidant personality disorder. Now we dive into schizophrenia. Schizophrenia is a chronic and severe mental health disorder that affects how a person thinks, feels, and behaves. It's marked by symptoms such as delusions, hallucinations, and disorganized speech. Schizophrenia affects about 1% of the population globally and has a profound impact on an individual's daily functioning and overall quality of life. Schizophrenia symptoms are typically categorized into positive, negative, and cognitive symptoms. Positive symptoms include delusions, hallucinations, and disorganized thinking. Negative symptoms are characterized by a lack of motivation, diminished emotional expression, and poor social functioning. Cognitive symptoms affect memory, attention, and executive functions. Diagnosing schizophrenia requires a thorough assessment based on DSM 5 criteria. The symptoms must persist for at least 6 months, with at least 1 month of active phase symptoms such as delusion or hallucinations. Clinicians use a combination of clinical interviews, standardized questionnaires, and a detailed medical history to make an accurate diagnosis. Treating schizophrenia effectively requires a comprehensive and individualized approach. Let's discuss the primary components of treatment. Antipsychotic medications are the cornerstone of schizophrenia treatment. They help manage symptoms by affecting neurotransmitter activity in the brain. Typical antipsychotics are first generation medications like haloperidol and chlorpromazine are effective but may have more side effects. Atypical antipsychotics are second generation medications such as risperidone and olanzapine. They generally have a better side effect profile and are often preferred. Psychotherapy alongside medication therapy is crucial. Cognitive behavioral therapy helps patients identify and change negative thought patterns and behaviors, reducing symptoms like delusions and hallucinations. Family therapy educates family members about the disorder and improves family dynamics and support. Supportive treatments address the broader impacts on a patient's life. Rehabilitation programs develop skills needed for daily living, such as managing finances and personal care. Vocational training assists in gaining employment skills, improving quality of life. And lifestyle and self care are vital for overall well being. Regular exercise helps reduce symptoms and improve mood, and a healthy diet supports both physical and mental health. Combining these treatments can significantly improve outcomes and quality of life for patients with schizophrenia. As we wrap up our presentation today, we want to leave you with a few coding tips for behavioral health. When documenting behavioral disorders, your provider should be encouraged to document to the highest specificity known. The type of a condition, the frequency of the episodes, the current status of the condition, and the severity of the condition should all be assessed and documented so they can be reflected in the coding for each patient. Also, specific to dementia patients, you should include code Z91.83 to reflect wandering in dementia when present. Thank you for joining our educational webinar today. Please feel free to contact us with any questions you have related to behavioral health and substance use disorder coding. We have links to our external site where you can register for upcoming webinars. Please give your feedback on today's presentation using the QR code. Thanks to Missy and myself for the presentation. We will see you next month for our encore phases of cancer coding webinar. This concludes our webinar. Have a great day.